still not used to this whole Zoom thing. So if anybody's open to it, I would really appreciate it. And for those of you who do have your cameras on, thank you. And thank you, Chandler and Bailey and Avi, for bringing me here to be able to speak with you today. So a little bit of background on me is I finished my training in family medicine in 2008. And I'm from California originally. So I finished up training in Los Angeles. And once I'd always had an interest in nutrition. When I went into medical school, absolutely. And I had envisioned doing a lot of nutrition. But I think what I would say is by the time medical school and residency were done with me, I was pretty convinced that nutrition would not be a major role, like it could not play a major role in my practice. And it was so subconscious when I think about it, when I go back into it. It was more that, you know, it's really great for preventing disease, but actually for treating disease, it just wouldn't do it. It wouldn't cut it like our medications did. And that was basically, I think, the underlying message from my training. And that's how I practiced medicine. About 2 to 3 years into my practice, I happened to stumble upon a documentary that our local health food store was playing one night. And it was about a local physician, Dr. Gabriel, who was in Patagonia, Arizona, and he was actually reversing diabetes. And I just felt like, well, I don't know if that's possible. You know, so I watched the documentary, and he has this kind of an immersion, and you go to his place and he puts people on a raw food diet, and he would document then for people who'd had diabetes for years, who were on insulin, within 2 to 4 weeks, the majority of them came off of their insulin, and many of them were not diabetic anymore. And I just thought, this can't be. I didn't go through 7 years of training, never saw anyone reverse diabetes, and he's doing it in a month. And, you know, I have to admit, he had long hair, he wears a beanie, he does a lot of meditation. And so I was like, he's just got to be some sort of a quack. It doesn't make sense. And so, but it was enough to pique my interest to start doing my own reading. And once I started doing that reading, I was opened up to an immense literature that is out there, that has been out there, of people healing through diet. And it just changed my practice around 180 degrees. It changed my diet personally, and it also changed my practice. And I used to think I was pretty healthy in terms of diet, but I realized how little I knew about nutrition, and what I was telling patients really wasn't very effective. And so no wonder it was like this self-perpetuating, you know, cycle, because I didn't know what to tell people, and then it wouldn't work. And then I would think, yeah, nutrition probably isn't that powerful. And so I just feel very blessed to have kind of walked in on that documentary, because it's really what changed my life and my practice, and renewed my, even though I was only in my 2nd or 3rd year in practice, it just renewed my vigor and my enthusiasm for medicine, which, as you all know, going into medicine, burnout is huge. And I think even in those early stages, I could feel that, just that kind of sense of lack of purpose, maybe, because we don't see the outcomes that we often would like to. So that's a long story, long answer to your question, but that's a little bit about me and how I got into nutrition. And then in terms of where I practice, I'm currently in Flagstaff, and I practice at a federally qualified health center. I had come into family practice thinking I wanted to do underserved medicine. And so that's why I chose a residency that specialized in it, and now continue to do underserved medicine. And I think for me, a really interesting challenge and a really, really fun one is to bring plant-based nutrition and lifestyle changes to a setting of patients where we usually think that, well, that's not really doable. And so that I very much enjoy.
That's awesome. Thank you for sharing. Can you tell us a little bit more about your practice, kind of what that looks like day to day and who you're primarily seeing and treating?
Sure. So in Flagstaff, we have a large Native population. We also have a significant Latinx population, but we're primarily about 75% Caucasian. And at the FQHC, the Federally Qualified Health Center, probably the mix of patients, we have about a third who are on our state Medicaid access, about a third who are on Medicare, and then we have I don't remember the percentage of how many are uninsured, but have sliding scale through our clinic. And then we probably have about 15% or so that are insured. And so when I started, I actually was working about 4 days a week doing clinic. Over the years, I've really gotten into teaching. So now my clinic time is down to about half a day to a day a week. And probably notably out of the clinic time, and something that I would really encourage the students and the pre-meds here to find out about, is group visits. Group visits are what I found is just an incredibly satisfying and effective way to deliver lifestyle medicine in particular, because group visits allow you to see 10, 12 patients at a time. But the magic is when all the patients come together and they share and they start problem solving themselves and they are able to support each other. And so when I first started this, I was doing a lot of one-on-one, working on nutrition, trying to bring back patients every week to be like, hey, how did you do this week? What's going on now? And it was very hard to move forward. I think it was, and I wasn't sure why I wasn't as effective as I wanted to be. But once we started doing the group visits, it really changed. And I think the excitement and the energy, not only for me as a provider, but for the patients, and the momentum was there for them. So if you haven't heard of group visits, I would just encourage you, if you ever get an opportunity to explore them or just look them up online, they're really a wonderful way to practice.
Thank you, Shipra. That's, oh, sorry. Someone.
No, I was going to ask like what the structure is for those visits.
Sure. Yeah, so usually what we'll do, my goal was to, so if some of you know like different programs in the field, Dr. McDougall's program, where there's like a 10-day immersion program, Dr. Furman has some stuff. These are all like really well-known programs where people go, they learn how to eat, they do great. And then, you know, they take those skills back home with them, but they require thousands of dollars. And so my goal in developing these group visits was, how can I do that in my patient population to the best of my knowledge? And so we just developed a weekly class where the goal was to treat it as much like an immersion as possible. And so how we structured them, we initially actually had people cooking during the class. And so let me start from the beginning. People will come in, they will get their vital signs. So it is still a visit. I chart on them afterwards to make sure that we get paid for it. Especially if they're on Medicaid or Medicare, which is our population, we can get it fully paid for. So it doesn't cost the patient anything. And so once they get their vital signs, we would have them come in. At one point, we were actually doing this at a junior high school in the home ec room so that everybody could cook. And ultimately, we ended up moving away from that and doing more demos within our clinic because there was some logistical issues. But basically they come in, we spend the first half an hour to 45 minutes checking in. Everybody talks about how their week went, what was a challenge, what was a success, and they're supporting each other and they're sharing. And then we'll spend about 20 minutes talking about maybe, where do I get my protein? How can I get my calcium? Whatever the topic of the day is. We always have food. We eat together every time. We have tons of recipes and cookbooks. And we always give them the recipes of everything that's in the class. Because we're a federally qualified health center, every meal we make is less than $3 because we want to drive home the point that this is affordable for our population. And then the last part, which took me a while to recognize, but that I now realize how important it is behavioral change. So we actually dedicate the last bit of every session to a topic such as, my family won't eat this way. What do I do? I don't want to cook 2 meals, right? One for my family or my husband, and then another for myself, because the majority of our participants are female. Emotional eating, mindless eating. So we talk about all these different behavioral topics that come up and really help problem solve. And then we give people a goal for the week, and that's good. That's it. We do blood work before and after, and I'm really excited to share with you that we're about to publish our findings from 1.5 years of doing the class. And on average, we were able to reduce systolic blood pressure about 12 points, total cholesterol about 20 points, and LDL about 16 points in across the 7-week span of the course. So what I can say, at least anecdotally, is that that's better than what I was getting one-on-one.
That's amazing. We've got a question here from Abby. She asks, are the patients involved in the group programs there through physician referral, or is it community members that join?
So it can be either one. We will put out, honestly, I think getting knowing the physicians in your community and bringing them on board is really helpful. One of the things that was kind of serendipitous for us, honestly, is we had a lot of providers and staff within our own clinic want to take the class in the beginning. And once they took the class and they saw the differences, they started referring our other patients. So that was a great way for us to start. And if there's any way, if you do it, get your staff and colleagues to take it. And then from there, we went on to the cardiologist in town or the nephrologist in town and try to get referrals from them.
We've got another question. Do you find it difficult to incorporate a plant-based diet into different cultures?
Actually, no. So what we do, and I was going to talk about this a little bit more later, so I'll touch on it now, and then probably it will come up. I think that's an excellent question. What we don't really, we provide recipes and dishes, but my thinking in terms of how to present plant-based lifestyles is that I talk about the food components that we know and the food properties that we know that improve health. So that could be something as basic as fiber. That could mean dark leafy greens. That could mean cruciferous vegetables. So whatever your culture is, let's find a cruciferous vegetable within your cuisine. Let's find a dark leafy green, because they will all increase your nitric oxide and help your endothelium and reduce your blood pressure. So it's not specific foods that you have to talk about, but food characteristics and food properties that I focus on. So does it matter to me what fruit you eat? Probably not. I'd be a little careful if you've got diabetes and you're eating a ton of watermelon or something like that, but those are few and far in between. We really want to work on food properties and start with what the person is eating, and then take a look at, okay, are you getting the fiber you need? Are you getting the dark leafy greens you need? And then mold and work from there.
This is a great segue. Can you talk to us a little bit about your approach to discussing plant-based eating with your patients? A, how you do it, B, kind of what the basics are that you talk to them about, what are the strengths of this lifestyle that you like to tell them about, and maybe what resistance you see in patients?
Okay, sure. Yeah, I'll probably forget some of those. So you can.
It's a loaded question. We can go back to it.
Okay, so, honestly, I think of plant-based nutrition as one tool in my toolkit. I'm a physician first, and if plant-based nutrition isn't the tool I need at the moment, I don't bring it up to everybody. And so I would just kind of recommend, just keep that in mind, that where has it been shown to be effective, and then absolutely where it has good evidence, let's bring it up. And so how do I bring it up? I don't always talk about it or introduce it as plant-based nutrition. I really do talk about properties such as, well, first of all, I like to focus on the patient's why. So if they're here for hypertension, right? What is it? Good nutrition is usually not an end in and of itself. It's exciting to me. It's not exciting to my patients, right? A low triglyceride level is probably not that exciting to most of my patients. So I need to find my patient's why. And it doesn't matter whatever way you practice, that's the bottom line. So what is it? Is it being alive for their grandchild, seeing their kid get married, being able to walk their dog without having to stop, being able to kneel down and pick something off of the floor without feeling awkward. It could be something really small and every day, it could be something big. But finding that why, and I usually will ask them, is there anything in your life that you would really like to do, but you feel you're limited because of your health? So you get right into that. What is it that you really want? Now, once I've got the why, the nutrition and the diet is a means to an end. And that's where you're going to always they'll have that purpose for what changes that they're making. Because in the beginning, when you change this, it's not pleasant, right? It's really scary, it's hard, it doesn't taste as good. You don't have that comfort. So you really need to have a strong why. And so when I bring it up, if they're here for hypertension, they really want to be able to go for a walk with their grandchild, but they just feel so tired. Let's talk about energy. Okay, so that's how I bring it up. Well, what's going to give you more energy? Hey, did you know dark leafy greens can help your blood vessels dilate so that they're like this and then they're like this? So you've got all this more oxygen coming to your muscle. So that's how we can introduce it. Or did you know that exercising, it doesn't have to be diet, but exercising can help you build mitochondria, and then give them kind of a few options to work with. And let's then kind of work and adjust your diet and activity. And then ultimately, as they kind of pick up some stuff, if they get more interested, I do bring, it's not that I avoid whole foods plant-based, the term, but I think the idea is to increase food components that will really enhance their quality of life.
That's great. What about resistance? Do you ever find it challenging? Patients don't want to change their nutrition, or are they often pretty open to it because they want to see these lifestyle changes?
Yeah, I would say both. And I would say over time, I've been doing this now for about 6 years. Over time, my patient panel has kind of adjusted itself in a way, because the people who come to me have heard that I do nutrition and that's exactly what they want. So it's been super satisfying for me. I just have like the most motivated patients, even in my FQHC setting. So, but there's still a good number that are not interested. And I think the bottom line is to recognize my role is not to convince anyone of anything, right? I'm here to provide information. And so when I present options, I usually will present diet or exercise or lifestyle, stress reduction, something else, and pharmaceuticals. And then my patients can choose. I'm happy to tell them the pros and cons of each. I'm not going to buttercoat, or what is that the right word? I think
Sugarcoat? No.
Sugarcoat.
Great.
Sugarcoat the side effects of medication, right? Because I'm not here to convince them of that either. And yes, every medication has a side effect, but the pro is that it's easier to do. And you might be in a place in your life right now where making a big lifestyle change is just not going to happen. And I want to respect that. And I want to let the patient know that they are absolutely in charge, because that's the way to engage our patients and empower our patients. Ultimately, they're not going to make long-term changes because they're doing it for us. They're going to make long-term changes because they're doing it for themselves. You can force somebody to take 2 weeks of an antibiotic, right? And kind of pressure them to do it. You can't pressure somebody to make a lifetime change. So that's where patient activation, patient engagement becomes key, and patient empowerment. So the first thing that I feel like I need to establish is you're in charge. I'm here to support you unconditionally. And I respect where you are in your life. because if this is not the right time, I respect that. My job is to get you to functioning optimally for whatever your circumstances are at the moment. And I think offering that respect, it will save you a lot of headache and hassle, and it will save the patient a lot of guilt and feeling like they're not being able to do what they're supposed to do. And it'll help you build that rapport that you so need in this process and journey.
We had a question about behavior change, which you may have just answered, but what do you feel like are the best tactics for behavior change? Do you think it's this patient empowerment primarily?
I think so. And I always put it back on the patient. What would you like to do? Where would you like to go with this? And then they can say what they want. And I can always say, can I give you a little bit more information based on my experience and make sure that I get their consent? And all of these are really the foundation of all of this is motivational interviewing. And so for the students here, I would just encourage you, if you don't already have it in your curriculum, to get trained in motivational interviewing, because if you're interested in behavioral change, that is absolutely, it's just a very effective technique to use. And it doesn't mean, because your goal, I think if you go in with your goal being like, I'm going to get 70% of my patients to eat this way or improve their diet, I think you'll be frustrated, because I think your goal needs to be adjusted to, I'm going to help my patients be the best they can be in their own journey. And that takes a lot of pressure off of you to have to force changes. And it allows the patient to have that, develop that autonomy. And if you go into primary care or somewhere where you have continuity of care, you can use that time to build that relationship and that trust. And that does really carry you far, so that once you've known that patient for, let's say, a year or two, you can say, hey, can I make a suggestion? Here's a thought. What do you think of this? I know you've told me, it's really hard to, you still are not feeling the energy that you want. How about something like, I know you like avocados. I know you like this. Would you be willing to try a green smoothie with avocados? I don't know, something like that. And so that idea, because then you have that rapport and you really can be a partner with them.
That's great. Eleanor had a good question. It sounds like you are framing these discussions in a way that doesn't directly discuss weight. Have you found that this is most pragmatic and increases compliance, or is there another motivation?
You know what, I go by what the patient wants. So if the patient's why is, I want to lose weight so that I can feel good about myself, then I will use weight. And I will say that, and I'll preface it, I absolutely support that, because I know when people reduce weight, that their health improves. And, just by reducing weight, we could get your blood pressure to come down and we could get your cholesterol to come down. So I'll tie it to the health, but I don't have a problem with using weight as a motivation for the patient. If they don't talk about their weight, I don't talk about their weight. I'm not, I certainly could, that can be really offensive. And it's the patient's why. It's not my why. It's the patient's why. Yeah.
Sonia wants to know, getting into a little bit more specific questions about the group visit model. How do you introduce the shared medical appointment? And then she also had a question about who cooks the food. Do you guys cook it together, or is it prepared beforehand?
We've done it a couple of different ways. And so just a clarification, how do you introduce it? Meaning to patients as like an opportunity for them? Okay. Yeah, I just say like, hey, we have these classes and we would love to have you join. Here's some of the benefits. And saying that, what I usually tell patients is that, the information is actually the easiest part. As you know, how to make the changes, that's the hard part. And that's what the class is geared towards. So that's how I introduce it. I have found, for me personally, doing a pre-class visit is really helpful. So before the weekly sessions, I do a one-on-one with each person signed up for the class. And this might be getting into a little bit more detail, but I'll tell you why I do that really quick. One is to make sure it's a good match, so I don't have a high attrition rate. Two is to build rapport with the patient, because oftentimes there are referrals from outside and I don't know them. And they're more likely to stay if they have a little bit of a relationship with you. And then three is to make sure there's no surprises for billing and coding purposes, so they're not billed stuff that they didn't expect, because I think that always leaves a really sour taste in anybody's mouth. Four is so that I can check on any health issues. For example, if they've got renal failure, I better not be giving them high potassium foods, right? Or if they're on warfarin, I better be watching what their INR is, or if they're on insulin, I need to be looking at that. So it's a safety mechanism as well. And then probably the last one is that it's a time to talk about behavior change. So I have them fill out a survey, like, why do you want to change? What is this that you're going to gain? What are you afraid is going to happen if you don't change? So we ask them these open-ended questions to just kind of prime them and help them with their why.
Polly asks, why do you think there is a lack of focus on nutrition in the majority of the healthcare field? When diet, exercise, stress reduction helps with a lot of different things, why do you think nutrition is neglected?
Yeah, such a great question, Polly. I feel like pulling out my hair about that one, because it's so ridiculous. I mean, I guess my first answer is that the way our medical system is set up, it is set up, right? It's a business model, and you can patent drugs, you can't patent nutrition. And that's probably why, drug therapies take off, is my guess. And that's why, for example, if we find that there's a certain property in food that, like, for example, antioxidants are really good for you, then they'll go ahead and they'll try to put it in a pill. They'll try to infuse it in your pork. They'll try to do anything to patent it and provide it to you in a way that they can make money. So that might sound a bit jaded, but I think, unfortunately, from my perspective, that's where we're at in the medical field.
Yeah, that's where the money is, certainly. Interesting question about gender. So you mentioned that most of your patients are female, and most of us here today are female. There seem to be more female nutritionists and female physicians interested in nutrition than males. What role does gender play in your group programs? And have you faced resistance from your male colleagues or patients?
Yeah, that's an interesting question. I haven't thought about that too much. So I will say that many of the males that do come to our group are oftentimes dragged by their partners, and they usually are a little bit quiet and reticent in the beginning, but then actually over the course of the sessions, they get friendly and they feel more comfortable. So usually if they have their female partner with them, it works out really well. But yeah, I've definitely had resistance. Like in the beginning, I ask everyone to do blood work, and the men just sometimes don't want to give blood work. They don't want to, they're very adamant, like, well, I'm just here to support my wife. So there is a gender difference. How does it come across in the class? It hasn't been an issue. I just feel like people know it's the tone that you set in the group of, like, and so I co-teach with a women's health nurse practitioner who actually does a lot of the cooking, because that was a question from before that I didn't answer. And I think both of us say that, hey, we're on this journey too, and we share our stories of what brought us to this, and we share our challenges. And I feel like that helps set the tone, that, there's no experts, there's no right way, but we're just sharing the information we've learned along the way. And yeah, by the end, usually, like by the second class, people will drop out. If it's not for them, they'll drop out. And then by the end, it feels really comfortable and friendly, and oftentimes people will stay in touch even after the class is over.
Can you talk to us a little bit about some of the outcomes that you've seen with patients in your group? You touched on it with your paper that you're publishing, but
yeah. So that kind of gives you the big overview. One of the patients I like to talk about is actually a man who came to our class. He also came with his wife, and I think his wife, actually, her numbers were pretty good. She didn't totally need to be there, but I think she was concerned about him because his cholesterol had been super high. His triglycerides were over 1,000, and he was in his early 40s. He also had chronic joint pains, which he thought he was going to live with for the rest of his life. He was a little bit overweight, but overall doing well. They have, I think, 4 or 5 children, and he works on the railroads. Flagstaff is a railroad town, so that's kind of that was his vocation at the time. But that would mean that he would go off for days at a time. It's a very male-dominated vocation, so there would be a lot of guys that would be going off working on the railroads, and so they would eat together and spend a lot of time together, and there was a lot of kind of kidding around. So when we brought this diet up, he had a lot of challenges because, first of all, he works with all men, and to go plant-based would be kind of just difficult. I guess there would be a little stigma, right? And we'd probably get harassed a little bit about it or teased. And then also, how do you kind of maintain that diet when you're out, working on the railroads? But his wife is incredibly industrious. And so they got a big like igloo, and they just, she would cook food for days for him. And he really got into it. He started losing incredible amounts of weight. He's relatively young, he's in his early 40s. He actually, his cholesterol went very low. In fact, he didn't even tell me during the class. He should have, but he didn't. But he just took himself off of his statin. And despite that, at the end of the class, his cholesterol was just, I don't remember the number now, but it was incredibly low. It was lower than when he started, despite coming off of the statin. His joint pains went away. He just had so much energy, where he felt like before he was kind of dragging himself and couldn't invest in his kids as much. But now it just feels like he's got all this extra energy, and started going to the gym because of that, in order to kind of use up some of that energy. And he just, at the end, it was just touching. He just said, I feel like I've got my life back. And he had anticipated, even being in his early 40s, a life of pain and fatigue, which he does not have anymore. So that was one of the really satisfying stories, but there's many where people just, I think the empowerment of being able to take control of your health is just really, really satisfying. Regularly, we see people with prediabetes take the class and they go right back into the normal range. That's very, very common. Not as common to have people with full-blown diabetes go back into the normal range, but we do see people being able to reduce their medication within 7 weeks.
That's amazing. I think despite all of the resistance we in the plant-based movement face, hearing stories like that of just one person being able to take their life back is enough to keep us going. So that's great. Yeah. What approach do you take with patients who may be facing resistance within their family?
Yeah, I think that's a great question, because it's a complicated situation. So for us, what we do is, first of all, because you're making this change, it doesn't mean that anybody else in your family has to make the change. And we really advise against pushing children to eat this way in particular, because their resistance is just going to get stronger and stronger. And so we really work on ways to first, and that's part of that first visit too, is like, who's your support system and what are your barriers? So that if you identify, well, my family wouldn't eat this way, okay, would you be willing to talk with them about why this is so important for you to try this out and do this class? And can you ask for their support? Not that they have to eat this way, but that they will not, kind of like take jabs at you, make fun of the food you're eating, or whatever, little things that families often do. And so try to set the tone up, so that as you go into this, you have a plan with your family. And then also reassure them, if you're the cook in the family. I'm sorry, that's my phone. I'm gonna just turn that off a if you're the cook in the family, that you reassure them that there will be something that they would like for them to eat if, if nobody else is willing to take on that role. Some people will be like, oh, sure, my so-and-so will cook their meat. I don't have to worry about it, or their dairy or whatever. And other people are like, no, I'm the cook. I need to do this. And you don't want the patient to feel like they're not fulfilling their obligation and their duty, right? So then we talk about, well, what are easy things you can do so you're not tempted and you're not cooking 2 meals? So for example, if there's like meatballs or fish, or there's something frozen in the freezer, that you put it as a side dish. So there's always something that can go with the main dish, but you're not then cooking a whole separate item. So that's one of the ways. But I think it's really important to address that going into it, and it can really determine how successful your patient is.
Thank you. Ethan had a great question. A lot of Indigenous people have had their traditional foods access removed or taken from them. Have you been able to integrate into your practice that cultural component?
Yeah,
Survival.
it is a great question. I have to say, in the class, we probably have not had as good representation from from different cultures. Our class has been more heavily Caucasian. Because Native Americans are a major part of our patient population, we have had some Native Americans in our class. I usually refer them to resources like the Power Plate, put out by the Physicians Committee for Responsible Medicine. They've done incredible work, really working with the communities out here, New Mexico, Arizona, and they have a lot of dishes. They're actually, the Navajo president is now plant-based. And so kind of being able to connect them with some of those ideas and thoughts, I think are really helpful. But I don't, we just talk more about food components. What is it that you like to eat? How can we make that healthier?
Great. This kind of segues nicely into our next question. How would you suggest medical students and health professionals seek education to be able to offer this approach to patients? Where can they learn more?
Yeah, that's so hard, right? Because you're probably not going to get it in school. So I think starting this club up, if that's if that's a direction you go, I would so recommend it. And consider doing a lifestyle medicine interest group under the umbrella of the American College of Lifestyle Medicine, because they can offer you kind of small grants to put on different activities. And then they can provide support if you want to start kind of pushing your faculty and deans towards adopting more nutrition and lifestyle medicine. But that's a multi-year project. So if you're graduating in the next 2 years, what do? I would highly recommend going to the Plantrition Project, which usually happens in September. It's usually in California, so it's at least on the West Coast. It is an expensive conference. It's usually about $900, but I bet they have really good student discounts. So I would look at them. They do feed you very, very well, and I think that's why they're expensive. So the other one is the American College of Lifestyle Medicine, and they do have a trainees kind of rate for their conference. But I think going to these will really keep you inspired and keep you motivated, especially as if you bring up these topics and it's not really paid much attention to, or it's not taken seriously in your school curricula, you'll see amazing clinicians and scientists who are doing this on a daily basis and getting amazing results. So just to keep yourself motivated, I think it's so important. Other things you can do are what I feel like a basic easy thing to do is Michael Greger's just regular. He has about once or twice a week, he comes out with a video on some sort of nutritional topic. It's amazing. And I think just having that in your inbox as a constant, oh, hey, he's got another 5-minute video. As med students, it's really, really hard to carve out time, but we all have 5 minutes we can listen to a video on, and he's so entertaining. So just doing that, because I think it's the little things that keep reminding us, why are we doing this? Why did I want to be plant-based? why did I think nutrition was important? And I think that's a really effective strategy to, over time, build and in a very kind of steady, slow way, build your foundation.
Thank you. And COVID has been difficult, but with Plant-Based Utah, that's kind of what we're trying to do, is bring these speakers that the Plant Nutrition Projects get. We did have Michael Greger on our schedule for 2020, which unfortunately we had to cancel. But if there's any speaker or topic that any student or non-student wants to see, send me an email or leave it in the chat, and we will do our best to, do a webinar event, or in the future, hopefully in person. Okay, next question from Polly. How do you coach your patients in the cost difference of a plant-based diet when it is typically more expensive? And I will add, is it typically more expensive?
It is. I like the caveat. Yeah, I would say it's not, because my patients often have told me that they spend less, and they didn't realize how much they were spending on their meat, and the dairy is expensive, like the cheese, but probably more than that is the processed foods. When you think about how little food you get for how much price, like cereal, you get probably what, 8 ounces or something for $4, $5. If you're buying Rice Krispies or something like that, it's really, really expensive. And I don't think we realize that. So when people do change over, and we talk about, we give them a lot of ideas, like how to buy bulk, how to buy frozens, what's the most economical way to get a vegetable, how do you make sure that your vegetables don't go bad, all those things where we feel like we're kind of throwing money away. We try to help people with ideas. For the most part, we have not had patients have difficulty affording a plant-based diet, and several have been very clear that they've saved like a third. Some people have even told us a third of their grocery bill by going plant-based.
Yeah, especially with staples like rice, beans, lentils, those things are often a lot cheaper than we realize. Does anyone else, okay, let's see, Ethan has a question. Do you ever talk with your patients about gardening to offset any potential cost issues, or, just being able to grow their own healthy food?
I don't bring it up. We have a lot of gardeners in Flagstaff, even though we have one of the shortest growing seasons in the country. It's amazing what people will do to garden. And I feel like people are far more adept at it than I am. So usually, yeah, I guess I just haven't thought of bringing it up, but we could. I just don't think people even have to go to that extent to save money, to be honest.
Right.
Because we'll talk about like canned beans, are they okay? Or, and yes, they are, but, make sure we'll tell them what to look for. And compared to what they are currently spending, I think they don't have to go to gardening. If they want, that's wonderful. There's obviously lots and lots of benefits of gardening.
What timing has worked best for you for the group visits? Mornings, afternoons, typically after work in the evenings, weekends?
Yeah, that's really good. It depends on your patient population. For us, we were doing evenings, and then we really had it coincide with dinner. So we would usually start at 5 o'clock and go till 7 or 7:30, and that would include dinner. So people, for the most part, once a week could get off of work a little bit early if they needed to. Flagstaff is really small. It only takes about 15 minutes to get from one side of town to the next. So it's worked for us. And 5 to 7 felt good. So we can eat dinner around 6.
Any barriers to eating plant-based for someone that's pregnant? Do they get all the vitamins that they need?
Absolutely. Yeah. There's always like the concern. So first of all, the biggest thing that we always give women in prenatals and during their pregnancy is folic acid. Your folic acid levels will be incredibly high if you are eating a proper whole foods plant-based diet, because the name folic comes from foliage, because it's ubiquitous in our green leafy vegetables. And so first and foremost, the biggest thing we worry about is the folic acid. So that is already solved in and of itself. They can still take additional folic acid. It's not going to harm them in any way. We do get concerned about, like iron levels, because iron does go down. So they can still take the same prenatal vitamins. There's not really, they will have to take a B12 for sure, whether they're pregnant or not. And then in terms of calcium, I would give the same recommendation I would give to a non-plant-based woman. So there's not really any concern.
Great. Does anyone else have any questions? I think I've hopefully hit on all the questions in the chat. And if you do, feel free to unmute yourself and just ask.
So many questions. This is great.
Yeah, thank you, everyone.
Thank you.
So participatory.
This is Sonia. Can you talk about your calcium recommendations for the general populace?
Yeah, you hit on a really sensitive one. Okay, so this one's is kind of complicated, but what we talk about is, if you look at worldwide, what are the calcium recommendations? They vary anywhere from 500 milligrams a day by the World Health Organization to about 700 milligrams a day in the European Union, to 1,200 and sometimes 1,500 in the US, right? Depending on if a woman is pregnant or postmenopausal. When you look at the studies that have been done ever since the 1980s, we do not see a correlation between higher intakes of calcium and we actually see an inverse correlation between higher intakes of calcium and hip fractures. Because the bottom line is not bone density, but actual fracture risk, right? And so what I like to talk about is that bone density is but just one factor in one's hip fracture risk. You also want to look at like quad strength, vision, balance, family history. So there's a ton of other environments. There's a ton of other factors that go into hip fracture risk. And I think because of DEXA scans, talking about our commercial kind of foundation in medicine, because of DEXA scans, we kind of identify bone density as like the major contributor, which is not. So that being said, taking more calcium supplements, the USPSTF came out with recommendations, I think in 2018 or 2019, where they are not recommending calcium supplementation for the reduction of hip fractures unless a woman is in a nursing home or very high risk of fracture. They do not make any recommendations for women who already have osteopenia or osteoporosis. So because the data is not showing even calcium supplementation or calcium supplementation with vitamin D prevents hip fractures. So it kind of leaves us in a difficult position. What I usually recommend is that first, and then the additional, sorry, that you can, I probably am going to go into more detail than you might have wanted, but I want to do justice to the question. So I'll try to be succinct. The other thing is that we know that in calcium supplementation, there is an increased risk of cardiovascular disease or cardiovascular events. It's small, but it is statistically significant. And so the way I describe it is, imagine if you were taking like a little capsule like this, that's got 1,000 milligrams of calcium, right? And then you swallow it. All of that, so you've got gobs of calcium that's swimming through your blood vessels, and some of it's going to seed out and it's going to distribute or kind of deposit into your blood vessels. And what we see, or what the hypothesis is that there may be reduced elasticity of the vessels, which contribute to cardiovascular events. There's another hypothesis that says there may be increased clotting from high levels of supplementary calcium. If the calcium is from food, we do not see that. We only see it from supplements. So that being said, I recommend cutting the calcium dose. If people can take it 2 or 3 times a day and take smaller doses, that's probably safer. Always having it with food. We don't really see that above somewhere like 600 or 700 milligrams of calcium, that hip fracture rate goes down. So for somebody who does not have osteoporosis, really heavily recommend physical activity, weight-bearing activity, not just walking, but walking up hills, carry weights with you if you can. And then green leafy vegetables, because we know that there's also a positive association with vitamin K status, magnesium status, and then the green leafy vegetables are a decent source of calcium as well. So that's kind of some of the recommendations that we give.
So I know you talked a little bit about this at the symposium we went to a few years ago, which was awesome. But I was wondering if you could touch on, do you ever have patients worried about soy? I know that there's a lot of like fear out there about the myths about soy. I was wondering if you could touch on that quickly.
Yeah, we did talk a lot about soy at that conference. So yeah, I do. And I don't know if this is the most effective, but my approach to it is just to nip it in the bud. Without them even saying anything, I'll just say, I know in the media this comes out a lot. Let me tell you, this is what the research says. And it's not even controversial. And if it's a woman, I'll be very, very clear that soy intake has been very, quite strongly associated with reduced development of breast cancer. Women who have breast cancer have a better survival rate, and women who have survived breast cancer have a reduced recurrence rate. And I kind of just leave it at that. And then if they have any other additional questions, we can go into it. But that's my 2-sentence spiel on it.
That's great. I know we've touched on a lot and kind of been bouncing around. Does anyone have any questions as we wrap up?
I've got one last quick question. Sorry. I'm just curious on your recommendation for like moving towards plant-based, or even just like moving towards like a vegetarian options. Is it recommended to consult with a dietitian or physician before moving that direction to make sure, or like just kind of what are your recommendations in that area?
So if a patient has some sort of a chronic condition or any condition, should they consult with the nutritionist first? Is that the question? I think the challenging part with that is that many nutritionists are not as adept at plant-based nutrition. The American Dietetic Association has not been friendly towards that dietary eating pattern. Again, the politics comes in. They're heavily sponsored by a lot of the foods that we're trying to get people to avoid. And so, or the companies that make foods that we want people to avoid. So I don't usually send people to a nutritionist, but that being said, I agree. I do think it's important to do it the right way. Just like you can eat a poor omnivorous diet, you can eat a poor whole foods plant-based diet. And one thing a very quick thing that you could provide to patients to help kind of guide them is Michael Greger's Daily Dozen, because what it does is it gives you proportions, like 3 servings of whole grains, but 4 servings of fruit and 5 servings of vegetables, and then he breaks it down so that I always emphasize to patients, try to eat in proportion to the Daily Dozen so that you make sure that you're getting the nutrients that you need and you're not too calorie dense.
Thank you so much.
Sure.
Any other final questions?
Yes, I'm interested in the shared medical appointments and what infrastructure you have in place to make that successful. And that would be, personnel, perhaps scheduling, whatever factors you feel like have been sort of the key pieces to success, and then also tripping points.
Yeah, so again, the key piece to success, I think, is getting staff and other providers engaged. That really helped us. You absolutely need somebody who's going to be able to schedule for you separately and be able to talk to patients about the class and specifics about kind of costs or co-pays and how that works. I think that is really important to be able to have a dedicated person for that who's knowledgeable. Outside of that, I have to say our clinic was quite hesitant to do these group visits. And so we really didn't have a lot of other, I had my medical assistant who had to kind of figure out how to do all of these vital signs with, 12 people coming in at the same time. And so we kind of just had people come in a staggered fashion, or we would just have the medical assistant take people out quietly during the session to get blood pressures and vitals. So that was scheduling for the MA was a little bit different, making sure you have the right space and that it's available. That's going to be a big part of it. And other than that is if you provide food, and most group visits do not provide food. I found it really effective in ours, but many of them do not, or they'll do demos with sampling, and that's perfectly fine too. We did buy a small induction stovetop, so that's about $50. And then we got a Vitamix donated to us from the company. They actually sent us a refurbished one when we told them what we were doing. So we did it on a very low budget, and we were able to then just with those and like a pot, do a lot of demos, do green smoothies, do show people how to water saute, like all those kinds of basic foundational things we were able to do. So other than that, I don't think you need too much more. If you have some budget for recipe cookbooks, I think those are wonderful. We always put them out in the beginning of the class. And then we, people can, as they stroll in, they can look at them and talk with each other. It's kind of a nice way for people to engage with each other, or just kind of wait until class starts.
I will say, Sonia, I've had a great experience with getting a Vitamix donations. They're pretty generous. I think they've donated one for our conference every year. So I'm sure if you reach out. Well, it is getting to the 1 o'clock hour. Thank you everyone so much for joining us. This was a great turnout. And thank you, Shipra, for sharing your knowledge. This was so great to have you.
Yeah, this was fun. I really appreciate being here. Thanks, everyone.